Welcome everyone to our first part of a 3-series Interstitial Pulmonary Fibrosis webinar series. I just want to let you know that this is being recorded. And with that being said, I'd like to introduce Nomsa. She is our patient coordinator. Norms, would you like to introduce yourself?
Thank you, Ms. Good evening, everybody. My name is Nomsa Jali, and I'm the patient coordinator for rare diseases. Thank you, everybody, for just coming through at this hour, hoping we've all had our cups of coffees and teas just to keep warm, as it's still very much cold. Today is, as Missy has mentioned, is our first of the 3-part series of the Interstitial Pulmonary Fibrosis webinars, where we learn all things IPF, where we learn all things about lungs and the functionalities. So we have our lovely Marianne, who's going to be giving us an amazing presentation in regards to that. Me as a patient coordinator, my sole focus on today's webinar is the patient journey throughout IPF and everything IPF. And I would like to have Marianne to introduce herself.
Thank you, Nomsa. Thank you, Missy. So my name is Marianne. I'm a genetic counselor. I started at Rare Diseases in February. And I've been tasked with chatting to you guys today a little bit about what is interstitial pulmonary fibrosis. So without further ado, I'm going to share my screen and we can get cracking. Okay. Give it a second. Right, here we go. Can everyone see that clearly? Okay, dokes. All right. So I think any talk about interstitial pulmonary fibrosis, it's a really big sort of mouthful of words. So let's really kind of break it down. And I think any kind of start to a talk really needs to go into the anatomy first before we go into anything else. So let's talk a little bit about the respiratory system. Okay, so our respiratory system is broken up into the upper respiratory tract and the lower respiratory tract. I just want to make sure that everyone can see the slides, but not the notes or anything.
Sorry, Marianne, can I ask a question? Do you want to be asked questions as you go or at the end of the presentation? You
can ask me as you go if you want to. I don't mind. Perfect. Make it a little bit more interactive. Okay. Yeah, you can't see my notes, so you can just see the presentation, hey?
Yes.
Yes, perfect. Okay. So as I was saying, we can break down the respiratory system between the upper respiratory tract and the lower respiratory tract. And really the function of the respiratory system is to aid the body in exchanging gases between the air and the blood and between the blood and the body's billions and billions of cells. So the upper respiratory tract can be broken down into the nose, the pharynx, and the larynx. So going down towards the lungs. And the lower respiratory tract, the little purple section, is really anything that's all in the chest cavity. So we're talking about the trachea, the bronchi, the lungs, and the diaphragm. There's the diaphragm underneath the lungs. Okay, it just kind of helps to give us a picture of what are we talking about and what are we looking at. So let's zoom in a little bit and look at the lungs. So we know that here's our trachea, following, of course, the picture from previously, and the trachea goes kind of down into these bronchial tubes and then splits into these bronchioles, which look like little trees. And at the end of all the bronchioles are where the magic happens. So that's where your alveoli are. So when we breathe, the air enters through our nose and our mouth, and it travels down the throat into this trachea, and then into the lungs through the right and the left bronchial tubes, and then into the smaller bronchioles, and eventually towards the alveoli. And each alveoli is covered in the tiny blood vessels called the capillaries. So I say that's where the magic happens because that's where the oxygen and the carbon dioxide exchange happens. So now when we talk about interstitial pulmonary fibrosis, as the name implies, we're talking about the interstitium. So what is the interstitium? So this is a really nice diagram that I found that shows you the tissue or where it's located. So here are alveoli with our capillaries on the outside. And really it's that layer of tissue that sits in between the blood vessel, the little capillary, and the alveoli where your oxygen and your carbon dioxide is being exchanged. So it's really important that that area, that interstitium, is healthy so that we can get some good oxygen and carbon dioxide exchange happening through that space between the blood and between the alveoli, where your air is coming in. So this is another picture that kind of shows it a little bit different angle. Again, here's your capillary at the bottom, and it's carrying your oxygen and it's exchanging your oxygen from the alveoli for your carbon dioxide that is picked up through the body. Okay. So moving on to what we call interstitial lung disease. So any disease that affects the interstitium is called interstitial lung disease. So as the name implies, it affects the interstitium. And it's really not just one condition. It's more than 200 different, it's a group of conditions, and there are more than 200 of them. But they're grouped together as they share similar pathophysiological mechanisms, clinical features, and findings on radiology. And we call interstitial lung diseases, of which pulmonary fibrosis is one, we call it a restrictive lung disease because people with any kind of interstitial lung disease aren't able to fully fill their lungs with air. So your lungs are restricted from fully expanding. Okay. So when we're looking at these interstitial lung diseases, some of them can cause scarring. Some of them can cause inflammation, again, of that interstitium that we were looking at just now. And some of them can cause inflammation and scarring on the interstitium. And the scarring obviously makes it very difficult to breathe. I mean, if you think about it, what you need is that tissue to be nice and healthy, but when there's scarring, that oxygen and the carbon dioxide can't be exchanged as easily. So the lungs get very stiff, they get less elastic, and what we want is that we want them to be able to be elastic and be able to move and expand so that that gaseous exchange can take place. So you're less able to move and take oxygen from the air that you breathe. And obviously, as the scarring increases, your lungs are less able to expand to allow you to take deep breaths, and the level of oxygen in your blood can start to drop. So it really kind of gets to a stage where breathing feels like hard work, and you can feel breathless from everyday activities, even like walking. So as I mentioned briefly, pulmonary fibrosis is an interstitial lung disease. So it kind of falls within this interstitial lung disease, this family of interstitial lung diseases. And the interstitial lung diseases fit into the larger kind of sphere of all lung diseases. When we're looking at things like cystic fibrosis that affects the lungs, we know that's a genetic condition passed on through families. We're looking at asthma, we're looking at chronic obstructive pulmonary disorder. So lots of different types of lung diseases, but we're really zoning in on those interstitial lung diseases. And then from there, we're zoning in more on the pulmonary fibrosis. Yeah. So when we're talking
about... Ask you something?
Yeah, go for it.
Sorry. No for somebody who has interstitial lung disease, is it possible for them to also get cystic fibrosis as well?
Yes. Okay. I suppose it could be.
So they can have the both. Okay.
I'm sure you could have both. Yeah. I mean, it's not impossible.
Okay. All right.
Yeah. It's almost
so
like
interstitial lung diseases can lead, but it can lead to other diseases as well.
What can, say that again, Nomsa?
Interstitial lung diseases can also lead to other diseases as well.
I'm not sure that they would lead to other diseases. Cystic fibrosis is quite something different. So you could have the two together, but it's not like cystic fibrosis would cause
this. Okay.
Well, it would be, might be part of the condition. So you'll see later there are different genetic conditions where interstitial lung disease is part of it. It's just one symptom of the greater disease.
Okay, perfect. Thank you.
Okie dokes. Okay, so when we're looking at pulmonary fibrosis, what does the word mean? So we know that pulmonary refers to the lung, and we know that what fibrosis means is scar tissue. So really, when we're looking at interstitial pulmonary fibrosis, it's that scar tissue building up in that interstitium between the alveoli and the capillaries, making it hard to breathe ultimately. Okay, So what are the signs and the symptoms of pulmonary fibrosis? So the progression of pulmonary fibrosis is highly variable, but the initial sort of characteristic symptom is shortness of breath, which is particularly noticeable during exertion, such as when you're exercising. So as I said before, the scar tissue sort of makes your lungs stiff, and stiff lungs are very hard to stretch. So your breathing muscles have to work extra hard just to pull in air with each breath that you take, okay? So your brain sort of senses this extra work, and it lets you know there's a problem by triggering that feeling of breathlessness when you exert yourself. Okay, another symptom of pulmonary fibrosis is a dry, hacking cough. Also fatigue and weakness, but sort of that extreme tiredness. So no matter how much you sleep, you're always feeling tired. And then symptoms, last one will be chest discomfort. So just to say the symptoms will worsen over time as that lung scarring sort of increases and progresses. Ultimately, some people also may develop what's called clubbing of the fingers and the toes. So clubbing is when the tissue at the bottom of the fingernails and the toenails swell, becoming wider and rounder. So it almost looks like your fingers becoming like a square shape. And individuals with pulmonary fibrosis have an increased risk of developing repeated chest infections, so sort of like a chronic pneumonia. Mm-hmm. Okay, so what causes pulmonary fibrosis? So the exact underlying cause is not yet fully understood. So we don't really know what it is. So there's lots of research into what it could be. So, but in a few instances, it's possible to sort of identify a specific cause. So one thing is medication. So prior or current use of drugs that are known to affect the lungs, like chemotherapy or a particular drug that's called methotrexate, just to name a couple. Methotrexate, I know it's used as like a cancer treatment, but also for other treatments. So that can cause pulmonary fibrosis. And then obviously it's easy to say, well, kind of that was the cause. Also, any kind of radiation treatment to the chest can also cause pulmonary fibrosis. Environmental factors like breathing in mold spores and bacteria and animal proteins. And I thought this was very interesting, that especially from indoor or caged birds. So there's another reason why birds shouldn't be a cage, but that's just in a cage. That's just my personal thoughts. Also things like autoimmune conditions. So some types of pulmonary fibrosis are more likely to occur when you have another condition, such as rheumatoid arthritis or something called scleroderma. And these are sometimes called the connective tissue disease-related pulmonary fibrosis. And then also being exposed, like occupational exposures, like being exposed to certain dusts or fibers or fumes or vapors, like asbestos, coal, silica. So people that work in the mines or the building industry and then exposed to certain occupational sort of hazards. And these ones are called the pneumoconiosis. Okay, so chronic exposure seems to be a culprit. However, in most cases of pulmonary fibrosis, a specific cause can't be found. So those, we call them idiopathic. So if there's no specific cause or no known cause, we call it idiopathic pulmonary fibrosis. And the vast majority are idiopathic. We're not sure of an exact cause. Okay, so pulmonary fibrosis can look a lot like other more common lung diseases, which can make diagnosis really challenging. However, it is an essential thing. Like, we really do need a diagnosis. And I think a lot of our rare disease patients can attest to that fact that we, without a diagnosis, you're kind of almost lost in the wilderness. Like, you need to be able to say to your medical aid or the person, treating you, this is what I have. So it's definitely, even though it's challenging, it is essential. And it's also, again, essential in order to ensure that there's optimal treatment and that, we know what the prognosis is, so we can have an idea of what the prognosis is. So in order to diagnose, there's lots of sort of investigations that need to be done. So you need to kind of take a thorough history and find out if there's any history of exposure. So to those certain drugs or dust or pollution, whatever it was that we spoke about on the previous slide. You need to look at clinical features of the person. Are there features that suggest that maybe they have some other kind of like syndrome or a condition? And part of that is pulmonary fibrosis, not necessarily pulmonary fibrosis on its own. Is it part of some bigger syndrome? There are blood tests that can be done, looking at like your full blood count, the imaging tests that need to be done, chest x-ray or a CT scan, pulmonary function tests, so those are the breathing tests, oxygen desaturation studies. So this test measures the oxygen levels in your blood. So you walk for about 6 minutes with a probe attached to your finger or your forehead, and then it measures your oxygen levels. And then ultimately a lung biopsy to help diagnose. So there's lots of investigations that need to be done in order to get it to try and get closer to a diagnosis. So treatment options, although there is no cure for pulmonary fibrosis, there are various different treatments that are available to sort of manage the disorder, and sort of several newer kind of options that are being studied all the time. So getting diagnosed and starting treatment as early as possible may help your lungs work better for longer. So it really is important to get a diagnosis as soon as possible so that you can sort of take the right treatment. So treatment is really focused on easing symptoms and improving quality of life as long as possible. And treatment includes all kinds of things like supplemental oxygen. So that will give your body the extra oxygen it needs in order to help you breathe more easily. May also increase energy and your strength overall. Certain medications that help slow down the lung scarring. There's also pulmonary rehabilitation, so staying active in a special exercise program may improve how much or how easily you can do your everyday tasks. And then ultimately, a lung transplant, which would replace either one or both diseased lungs with a healthy lung or lungs from a donor. But obviously, this is a major surgery, and it's not everybody is a candidate. So yeah, so those are the treatment options that are available if you have pulmonary fibrosis. Okay, so there's certain risk factors. Men tend to be more affected than women, so males more than females. Typically, if you're an older age, you're at a higher risk for having pulmonary fibrosis. Smoking is a big risk factor in everything that I've read on pulmonary fibrosis. So you really don't want to be a smoker. Besides the cancer risk, and we're not just talking lung, we're talking things like bladder cancer as well. Definitely an increased risk for pulmonary fibrosis. Exposure to certain substances, again, the substances that we spoke about earlier, like the silicone or asbestos, radiation, those kind of things. Again, radiation treatment. And then some research is suggesting also that if you suffer from gastroesophageal reflux disease, that may also be a risk factor for idiopathic pulmonary fibrosis. And that's possibly because of the hydrochloric, the acid in your stomach always kind of coming up and damaging the lung tissue. And then, of course, family history. So that brings us nicely onto the, is it hereditary? Is pulmonary fibrosis hereditary? So what researchers suspect is that there's certain individuals with pulmonary fibrosis that are actually genetically predisposed to developing pulmonary fibrosis. And then certain exposures, like this chronic exposure, like exposure to certain dust or chronic cigarette smoking, will almost like trigger the condition. So that's almost like the current thinking. So a person who's genetically predisposed to a disorder would carry a gene or genes for the disease, but it may not necessarily be expressed unless it's triggered or activated by this chronic sort of exposure to certain elements like cigarette smoking. So what is a gene? So we talk about genes, we say, oh, there might be these genes that you have, you carry, you don't carry, but what does all of that mean? And this is where we come to my favorite part of the talk, because it's genetics, and that's where my passion is. So I think let's have a brief sort of overview of what is your DNA, what are genes, what do they mean? What do I mean when I say a gene? What am I talking about? So let's take it back to the basics, and let's look at a cell. So we know that our body is made up of millions and millions of cells. We've got skin cells and hair cells and blood cells, etc. And we know that within every cell, we have our DNA that sits here in the nucleus. And this DNA is packaged into these structures that we call chromosomes. So if you were to unwind a chromosome, you can then go right down into the DNA structure, and certain stretches of the DNA are the genes. And the genes are the instructions that are telling our bodies what to do. So we have over 20,000 genes on our chromosomes. And those are the instructions telling our bodies what we must, how we must work, how bodies must work, what we must look like, how we must grow. So everything our body does is because of these instructions, these genes. Okay, so if I was to take blood from you or from me, or one cell of the body, a skin cell, blood cell, whatever it might be, and we can look at it under the microscope and we can unravel our DNA and we can look at the individual chromosomes in our bodies. And that picture of our chromosomes is called a karyotype. And there's a picture of all the chromosomes in one cell of the body. So if you were to count them, there are 46 in total. You can see they're arranged in pairs because we get one from mom, one from dad, one from mom, one from dad, etc. Okay. And then I just want to draw your attention to these two chromosomes at the end, the X or the Y. So if you have two X chromosomes at the end here, you are biologically female. And if you have an X and a Y, you're biologically male. Okay, so I've now said that you get one from mom and one from dad. So how does that happen? Because we have to have 46 chromosomes in every cell of the body in order for the body to work properly. So let's talk a little bit about reproduction in terms of our chromosomes, which are carrying our genes, which are the instructions that are important, and which might predispose us to having pulmonary fibrosis. So here's mom and dad, or male and female, each have 46 chromosomes. So what happens in the female is in a very, like a natural process. This all happens obviously inside your body. You've got no control over it. 23 chromosomes, one from each pair, go into the egg. 23 chromosomes go into each sperm. Together, they come together. Fertilization happens. We get what's called a zygote, which has the 46 chromosomes. Great, everything's working fine. And we have the baby. So how does this relate to pulmonary fibrosis? Well, there is evidence of familial clustering. So where you have like maybe 2 different generations affected with pulmonary fibrosis, you can see that it's coming through a family. And actually a definition of familial pulmonary fibrosis is the presence of at least 2 cases of interstitial lung disease in the same family. So this is different from that sporadic type of pulmonary fibrosis that happens by chance or by this chronic exposure to other like things. But if there's this kind of familial pattern, it means there must be something going on within the chromosomes. There must be something going on within the genes. Okay. So there have been some genes that have been looked at and seen to be predisposing individuals to having pulmonary fibrosis. It's very important to point out here that they predispose you. It's not like what happens with some genetic conditions where if you have a mutation in a gene, you will get that condition. This is more of a, if you have changes to that gene, it predisposes you to getting pulmonary fibrosis, but it's not a guarantee. What the research is kind of suggesting is that you almost need like something else to contribute in order for it almost to be triggered, to be activated. So some of the genes that have been known now to be associated with pulmonary fibrosis, the first set are ones that are involved with what we call the telomeres. So if this is a picture of a chromosome, well, it is, not if, the ends of the chromosomes are called the telomeres. Okay, so they almost act like caps at the ends of the chromosomes, and they help to prevent DNA damage. So they're almost like keeping the integrity of that chromosome. But as the cells divide, you know, as they do continually, and as the body ages, these telomeres get shorter and shorter. So a natural part of aging is the fact that our telomeres get shorter. And at a certain point, the too short telomeres are thought to drive cell death. So what they've discovered is that they're actually these sort of telomere regulatory genes, these genes that are responsible for regulating the telomeres. And if some mutations in some of these particular genes, there are quite a few genes, so it's not a single gene thing, they're different genes, they actually account for 20 to 30% of familial pulmonary fibrosis cases. Okay, so that's These are the ones. So they actually, these two, this TERT and the TERC, if you read anything on familial pulmonary fibrosis, you see those two genes are important for making components of an enzyme, which is called telomerase, which maintains the telomeres. So in people with this pulmonary fibrosis of an unknown cause, so this idiopathic pulmonary fibrosis, these shorter telomeres are associated with a more severe disease and a quicker decline in lung function. But again, we need additional research to confirm how these shortened telomeres contribute to the progressive scarring that we see in the interstitium in the pulmonary fibrosis and the lung damage that's characteristic of this pulmonary fibrosis. Okay, so we know a little bit, but we don't know a lot just yet. Coming, I suppose, in time. The other set of genes are surfactant genes. So in the lungs, air comes into contact with body fluids, which creates this surface tension. So to lessen the tension and make breathing easier and more efficient, the lungs produce these specialized molecules called surfactants. So mutations in genes associated with these surfactants, this sort of production of the surfactant, such as these ones here, have been associated with familial pulmonary fibrosis. So again, to what extent is really hard to know. So these ones are less common and account for about 1 to 3% of familial cases. Another one I want to mention is this NUC5B gene, which sits on chromosome 11. It produces a mucus protein. So there's one particular variant that's found in what we call the promoter region of the gene. So the promoter region is almost like the, I want to say like the on switch for a gene, switches it on and gets it working. And if that sort of mutation or that change is present, it sort of predisposes individuals to pulmonary fibrosis. But how it actually works is still very much unclear. What we do know is that it increases mucus production, but how that predisposes to pulmonary fibrosis, we don't yet know. Okay, so I put this table in just so you can see that it's really not an easy discussion point in a way, this predisposition to pulmonary fibrosis. So these are the genes that are associated with maintaining the telomere. These are the ones associated with the surfactant. So there are lots of different genes, and this is the sort of the numbers of cases of familial pulmonary fibrosis that it's linked to. Okay, so they're almost like these rare variants in these surfactant and telomere related genes. They only explain the genetic basis in about a quarter of familial pulmonary fibrosis sort of families. So we know a little bit, we don't know a lot just yet. But what we do know is how these gene mutations are inherited. So for the most part, you can see down this little column, a lot of them say AD. So what we know is that they are inherited in what we call an autosomal dominant fashion. So what do I mean by that? Okay, so I've got this nice little animation that's going to explain that. So here we have the male, we have, let's say, dad, and we know that he has they're two of his chromosome pair. We know that he's got what we call a mutation in this one gene. Let's say it's for a telomere gene. So there is his one chromosome is working nicely, the other gene is not working very nicely. And we know that when it comes to making sperm cells, we know that, remember, one from each pair goes into the sperm cell. So we don't know whether the one with the mutation is going to go in or the one without. So let's say that the one with the mutation goes in. So there's a 50% chance that he's going to pass on that chromosome with the gene mutation that predisposes to pulmonary fibrosis into the sperm. Okay, here's mom. We know that she doesn't carry a predisposition to pulmonary fibrosis. So she doesn't have one of those gene mutations on her two chromosomes. We know that one of those will go into the egg cell. The egg and the sperm come together, fertilization happens, we have the baby, and we know that he got that one from dad and that one from mom. Okay, so with every pregnancy that this couple has, if he has this predisposition to pulmonary fibrosis, and it can also work the other way, it could be mom that has this predisposition, we know that there's a 50% chance of that baby inheriting that same predisposition. Okay. Okay, so we call that autosomal dominant. Okay, so I also mentioned briefly earlier that it also may be, this pulmonary fibrosis may be part of a genetic syndrome. So there are different genetic syndromes. I've highlighted this one in particular, Pomansky Pudlike syndrome. This is a syndrome that's characterized by albinism, vision abnormalities, and platelet dysfunction, which leads to prolonged bleeding. But in specific cases, affected individuals or people with this Pomansky-Pudlike syndrome can develop pulmonary fibrosis. So you can see it's not that they have pulmonary fibrosis on their own, it's part of a different genetic syndrome. So the doctor that would be doing the investigations to do the diagnosing, they would put together all the bits of evidence. They would see, okay, there's albinism, okay, there's platelet dysfunction, there's vision abnormalities. This could be Pomansky-Pudlike syndrome. And the people that put those puzzle pieces together, those are the medical geneticists. So they are the genetic specialists. They're the doctors who've specialized in genetics, and their job really is to try and diagnose and put together all these little pieces to try and find a diagnosis for people. So mutations in several genes are known to cause HPS, the Pomansky-Pudlike syndrome, and pulmonary fibrosis only appears to be associated with two specific mutations in those two genes highlighted in green. So even within a syndrome, only if you have a mutation either in this gene or that gene will you be at risk of having pulmonary fibrosis. So the genetics of it is really quite complex, and there's still very little that we actually know for sure. Okay, so if we were to try and establish if there's a genetic cause or if there's this predisposition running in a family, what you really want to do is you need to do a lot of investigations. You need to look at the medical history of that person. You need to do a physical examination, look at the family history. You've got to look at the age at diagnosis of the pulmonary fibrosis. If it's in childhood or in adults younger than age 30 years, that would suggest that there might be a mutation in one of the surfactant genes, whereas you've got to look for family history of features of a short telomere syndrome, because then that might point you towards the telomere genes instead of the surfactant genes. Pulmonary function testing, imaging, lung biopsy, and then ultimately molecular genetic testing. So in most cases, I think it's also, again, just to emphasize that genetically, the cause remains unexplained in up to 70% of cases. So the thinking really is that it might be not one gene contributing towards an increased risk of pulmonary fibrosis, but it might be a few genes or many genes kind of working together in conjunction with an environmental component. And those two together, it's almost like that perfect storm that brings about this predisposition to pulmonary fibrosis. Okay. Okay, so I'm a very fast talker, clearly. So in summary, just to say that this pulmonary fibrosis is a condition in which tissues in the lungs become thick and stiff or scarred over time. Obviously, with that thickening, particularly in the interstitium, the lungs then lose their ability to move oxygen to the brain and other parts of the body. Common symptoms include shortness of breath and a dry hacking cough. And in some cases, the fibrosis happens really quickly, while in others, the process is much slower. And what makes this progression of the condition so variable, we don't know. So again, there might be genetic factors that are almost like protective rather than harmful, which would explain why some people maybe progress faster than others. And then the condition is mostly idiopathic because the cause is unknown. So for the majority, we still don't know why it happens. And then when there are multiple family members are affected, we call it familial idiopathic pulmonary fibrosis. So many people with this condition and many people with this, the familial version, will live for about 3 to 5 years after diagnosis. The most common cause of death is respiratory failure. So the genetic predisposition, again, looks at the telomere regulatory genes that have been implicated and the surfactant genes. And for the most part, these gene mutations are inherited in an autosomal dominant manner. Okay, so really that's sort of this interstitial pulmonary fibrosis in a nutshell. It really is a condition that we can treat in a way, but we don't really know, we can't really stop it from happening. So I just want to say, we don't know enough yet about what's actually causing it from a genetic perspective, but hopefully with more research into it, we can know a lot more and then be able to tackle it and be able to diagnose a lot more frequently maybe than we are now. I just wanted to point out that this is you can find us, or you can find me at Rare Diseases, and there's a specific tab under resources for genetic counseling. So I encourage you to join our community. Please sign up as a patient, as a caregiver, and you can have access to our resources, and then you're very welcome to contact me with any other questions or comments that you might have. Thank you.
Wow. 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 Smashed it. What an amazing presentation. Very educational. You got me worried. Like, I'm worried. I've just recently started vaping and I think I'm the queen, but I actually think I'm not anymore. I actually think I'm not the queen of vaping anymore because, wow.
Yeah, the fact that not good, we don't know what the long-term benefit of, the long-term damage
exactly. You see, so that's why I think to myself, I'm not the queen anymore. I'm just losing the crown of vaping queen right now.
Funny.
Yeah, I am. I'm giving it away to somebody else because wow, I just didn't know. I can't imagine losing functionality of your lungs. It takes so much away from you. And the fact that contributing factors can also be medication, that is so sad because majority of people survive on their treatments and medication. That something like that is meant to give you life can also cause something else. It's just so sad. I literally feel like breathing, just
because you can.
just breathing and getting yes, I can just imagine the patients that go through IPF and the difficulties that they go through. And I actually think a lot about the maintenance that comes with having to be a patient and the importance of treatment for these patients. And having you had said to us that for after diagnosis, you can basically have 5 years. Wow.
If you have a familial one. It really depends on kind of, what the cause is. Like if it's one that's running through the family and it's one of those genes particularly, then that's where that kind of 3 to 5 years falls in.
Oof. So you mentioned that you can get it from age 60 and above. Is it possible for younger people? Oh, it is common. So for younger people, is it possible? Can kids also get it? Is it possible?
It is more, kids. I think that it's more, if it appears in childhood, it's more the kind of the familial form. So the one that you'll see coming through a family. So you'll definitely have a parent or a grandparent or an aunt or an uncle. It's more the familial form. But again, the progression and the presentation is so very variable. It's really hard to know.
Okay. So environmental factors, like how you were mentioning, like they don't play a role when it comes to kids or toddlers or teenagers. Do they have a role that they play?
I think it's more the environmental factors. It's more like a cumulative effect, like that chronic sort of impact of that chronic exposure.
Oh,
that's
okay.
More, so that's typically why the onset is later, because by the age of 50 or 60, you've had 50 or 60 years potentially of being exposed to certain environmental triggers.
Yeah. And when it comes to diagnosis, I'm assuming because there's pulmonary there, you'll have to see a pulmonologist if you feel like you might be going through something similar. So the one person who can give you a diagnosis will have to definitely be a pulmonologist, right?
Yeah, I think that the pulmonologist is the specialist you want to see.
Okay. Okay. And I'm assuming also a pulmonologist will also be responsible for treatment as well.
Yeah.
Perfect. Okay. So for somebody who's just who thinks that they might have symptoms, what do they do? Is the first point of contact will have to be the pulmonologist, or can they go to a GP and get referred from there to there, or do they just go strictly to see a pulmonologist?
Well, I mean, I'm not a doctor, so that's my disclaimer, but I definitely think you could probably go and see your GP first, and he could definitely run certain tests. But, I mean, really, the pulmonologist is the specialist, and I'm a huge fan of specialists, you know, just because, I mean, they're almost like those experts in their fields. And then also sort of like, especially from, if you want to know about, you know, if it's more inherited, then if it's part of a genetic syndrome, then you would go and see the medical geneticist, because again, they are trained to look at specific things to see whether you fit into a genetic syndrome. So it's the same with the pulmonologist. It's just specialists.
Okay, perfect. Thank you. That was, I'm changing my habits. Yes, the quite a few questions that have come through. I'm just, my disclaimer, I'm changing my habits. I'm definitely changing my habits. I have a question here for you. Is it possible to screen or test for genes that have been identified for IPF?
Okay, so I feared that this question would be coming, so I had a look. Not locally, not as far as I know. I've never seen anything, but Rare Diseases is currently in the process of putting together a lab hub of all the genetic testing that's available in the country. So watch the space, that's definitely coming. So that will be almost like a one-stop shop. So you could type in your condition and it would say, okay, this lab tests for that private lab, that state lab. So that's in the pipeline, that's coming, that will be very helpful. From what I know, I think you can only test for that overseas, which again, medical aids then won't pay for overseas genetic testing. And again, the testing is very limited in itself because, you know, you can test for the telomere related genes and the surfactant genes and that other one specific mutation in that one gene. But again, it's going to tell you about a predisposition. It's not going to tell you for sure that you're going to get pulmonary fibrosis or not. Again, you need to avoid all those environmental triggers as well, and don't smoke.
Yes.
So yes, overseas testing. Overseas testing, expensive, medical aid won't pay. Yeah, limited, yeah.
Oh, okay, wow. Is it appropriate? Is there appropriate treatment for IPF available in South Africa? Is this both in private and in state? Are state patients with IPF able to get access to treatment?
Okay, so in state you're asking, treatment for IPF available.
Treatment. Yeah.
I don't know, to be very upfront. I think that are you having a session with a pulmonologist? I think like a treating pulmonologist for someone who treats someone with, they'll be better placed to tell you what kind of treatment is available. I'm assuming that the medications that they typically put people on to try and prevent the scarring would be available. I don't know if anyone on the meeting can jump in. But yeah, that's definitely something that we need to find out about, like what kind of treatment is available in South Africa.
Okay. What is the estimated number of South Africans affected by IPF? Either familial or idiopathic or both? Assuming there is a prevalence from elsewhere in the world for us to calculate from?
Yeah, we can definitely use, and even the numbers worldwide aren't, there aren't lots of research into the numbers worldwide. I think there was, I've got a US one somewhere that I can look up for you. There was a US based kind of stat, but I don't know from a South African, there isn't, no.
Okay, thank you so very much for that. Would gene therapy be a potential future treatment?
Noms, can I jump in? Sorry. Just to answer the question about treatment in South Africa, there are 2 types of treatment available, but they are only in private healthcare at this point. However, patients are still encouraged to speak to a pulmonologist about these treatments.
And with that being said, Ms., so patients on state won't be able to get access to this treatment?
Unfortunately, not at this point.
Oh, man, that is sad. That is sad. And I can imagine not being able to access treatment also then forms long, it's just like maintenance for those patients. It also prolongs being able to get better and give you the opportunity to just have the best quality of life. Yeah, I hope things get better. I do hope things get better.
If you think about how many people in the state sector, if you think about all the mining companies and how many of their workers would have been exposed with that chronic exposure.
Yes, exactly.
Absolutely.
Yeah. Oh, so sad. Your last question for tonight.
That the gene therapy.
Oh, sorry, Ms. Yeah. Would gene therapy be a potential future treatment for familial IPF where the gene is known?
Well, I think that it wouldn't be one of the first conditions that you would look at for gene therapy, or that researchers would, because it's not the kind of condition where it's one gene, one mutation or certain mutations, and you can go in there and kind of try and fix that one mutation in that one gene, and then it fixes the condition. It doesn't work like that. It's different genes all contributing and environmental factors at the same time. So how can you target all those different genes specifically, especially when they're on different chromosomes in different places? So I think that's always the challenge with gene therapy, is how do you get something into every single cell of the body to go and fix the error without maybe potentially messing up something else further down along like a different pathway. And must remember that our like at the molecular level, there are lots of different pathways that kind of overlap. It's almost like a built-in protective mechanism in your body, so that if one pathway doesn't work, there's another one to compensate. But you might not necessarily know that until you start messing with the one pathway or trying to change it. So it definitely, I personally don't think it would be a particular condition that would be first line for gene therapy.
Yeah. Wow.
But maybe in like 50 years' time, in not when I'm long gone and.
Wow. The patient journey is actually very hard. It's patient journey from getting diagnosis to treatment to maintenance. It's so difficult. It's so difficult. And I wish our government would understand that for those patients who are not on private, because this is the only way. It's so difficult. It is honestly difficult for patients that don't know where to go, who to go to. And it's why we appreciate people like you, Marianne, who just give us the opportunity to just educate.
And the other thing, can I just add in quickly, is just what's always very important is that I think that for lots of different patients, they're very disempowered. So I think what's really important is to empower patients, to ask the questions, to push, to just really kind of say, well, like, what about me? I've got this symptom, you know, this is a problem, help me. How can I get treatment? What must I do? So all about empowering the patient in order to get better diagnosis, better treatment, faster diagnostic odyssey. So that's our goal. That's my final.
Oh, thank you so much. Thank you so much. So in closing comments from you, I'll have my own closing comments as well.
From me?
Yeah. Any closing comments?
Okay.
Yeah.
So yeah, just to say that it's actually it's very complex condition. I mean, it sounds very simple that there's the scarring and then you're unable to breathe, but really, why? Like, how have we got into that? Like, what's going on at the molecular level? What's going on at the genetic level? And it's really not the only condition that has this very complex sort of interplay between the genes and the environment. So lots of conditions are like that. And those are the hardest ones to kind of unravel. So my hope is that in the future we can unravel it more, and that a lot of money gets thrown into research, but also towards treatment for the patients that need it the most.
Thank you so much. I couldn't agree more. We need research, we need more done, and definitely we're manifesting it. I'm manifesting right now. Manifesting it. We're manifesting it. And my closing comments, I'm going to echo Marianne in saying, if you don't ask the questions, you're not going to get the answers. So it's always advisable for you as a patient to ask the correct questions from your healthcare provider. And with that being said, I have pointed out what you can do when you go visit a healthcare practitioner. Firstly, I'll say you need to know the reason for your visit and what you want to happen. You need to know what you want to happen. Before your visit, know which questions you need to be answered. Like the questions you have, you need to get those answered. And if you're somebody that kind of like forgets, it would be advisable to just bring somebody to help you ask those questions so that they will help remember the questions that you had previously, and they'll provide them to a healthcare provider, and they'll also remember what your healthcare provider has told you. And at the visit, write down the name of the diagnosis and the new medication that you'll have to take, the treatments, the tests that need to come with, and instructions from your healthcare provider. You need to just write down all of that information and get as much information as you can in regards to your diagnosis. Know why you need new medication and the treatment that is being prescribed to you, how it'll help you, the side effects, how it will enable you to do better, if it will give you your functionality or not. Get to ask your healthcare professional all of these questions. Is there a cure? Is your condition, can a condition be treated in other different ways? Just ask those questions, because if you do not ask those questions, nobody will give them to you. If there's one thing I've picked up from patients as well, is that the fear of asking healthcare professionals questions and wanting to find out more. They fear all of that. And when they fear that they don't get the correct information, then they'll consult Dr. Google, and Dr. Google will just tell them whatever he wants or she wants.
So true.
And this is where the problem comes in. This is where the biggest problem comes in, because now you have Dr. Google's information and you have your healthcare professional practitioner's information, and you're trying to combine the two and it doesn't make sense for you. So please ask the right questions. Know the tests that need to be done for you, the procedures, and if you get results from your doctor, just ask the doctor what they mean. Don't take results home and you don't know what they mean. That you've been told, okay, you have IPF, and then you get home, you're like, okay, what is this? What is that? What is this? And just ask your doctor of the expectations. What's going to happen if I don't do this? If I don't take medication, if I don't get tests done, if I don't do certain procedures, what's going to happen with me? I think that's the only thing you can do to help yourself, and also make life easier for your healthcare practitioner to help you. Because as a patient also, it's also a responsibility to know what is happening with your disease and how you can help yourself to make your life a little bit better. I know I've quit my vaping situation.
That's very quick.
I've lost my crown. I've lost my crown. And yeah, thank you very much, everybody, for just joining us, and for to Marianne for just an educational presentation. I've learned so much. And I promise you right now, the only thing I want to do right now is just to breathe properly. That is me right now. Thank you very, very much. And thank you, Miss. And thank you, everybody at home, for just being with us and engaging. We really appreciate it. Hoping everybody has a beautiful night. And yeah, cheers.
Bye.
Thank you, guys. Thanks so much.
Bye.
Bye.